So today we're going to have Bartlett updates in a case, and then next week we're going to talk about a very interesting lenacapavir case that Sonia has been managing in the clinic. And then the following week, I'm going to do an update on the literature regarding cabotegravir and rilpivirine resistance cases, which there is recently a review published on that. Later in March, we'll have updates from CROI, and then I'm very excited because we do have planned an obesity medicine expert who's going to come and talk to the group about strategies for weight management. That's Dr. Selvi Rajagopal, who I believe runs the fellowship for obesity training here. So that should be really interesting. And then later in May, HIV reservoir with Bob Silcano. So very exciting. Lots of things coming up. And then I will now turn it over. So I got you a few more people, Sheila. To Sheila and Stephanie, and then we'll have a case to finish, assuming that we have time at the end.
So I'm going to share my screen and, go through the slides for Stephanie. So, start slideshow. Now I'm sharing the wrong screen. Am I sharing the wrong screen? I think I am.
No sharing yet.
No sharing yet? Okay, hold on a second. Where did the share button go? Okay, so I think this is where I want to be. Am I sharing now?
Yes.
Yes.
Okay, cool. Just want to make sure I was sharing. Okay, Stephanie, hit it.
All right. Hi, everybody. I'll try to make this quick. These are our February 2024 Bartlett updates. Next slide.
Why is it not forwarding?
It's not actually in show mode. If you hit the bottom, the little, yep, one, nope. Oh, other direction. That little, yeah, there you go.
But is it not? Yeah, but I've lost where I'm going to the next slide. Resume slideshow. Why am I not? What is going on here? I got these three screens going and now I'm totally confused.
Can you click on from beginning and see what happens?
So you're still seeing the first slide, right?
We're not seeing it in like a we see it in like sorter
All right,
mode.
here's the next one. What do you see it in?
Like where we can see all the slides on the left side, and then the slide that we're looking at in the, so if you have it, if it's showing in two different places.
So let me just start over again. Hold on a minute. Let me stop sharing.
Okay.
I apologize. So now stop sharing. Okay. I'm going to stop sharing. I'm going to figure this out. Okay. So now I'm going to share screen 2, share. Can you see it now? And is it in?
Yes.
Okay. I just needed to, like, there was too much going on in my. Okay.
All right. So I want to give you guys just an update always how we're doing first. We meet with our CQI analysts, as quality initiative analysts, every month to discuss our progress, our workflows, and she always shares great news about how well we're doing. So I want to share it with you guys as well. So this is our performance from December. Metrics are always a month behind, so we don't have January data yet. But from December 2023, these are our core quality performance measures. And if you take a look, we have our breast cancer, colorectal cancer screening, controlling high blood pressure in our patients, managing their diabetes with checking their A1Cs, and our well visits. And we have one measure that's meeting target, that's our HbA1Cs that our CMAs are holding down in the zones. And if you take a look at our well visit 65 plus, we are within 5%. And if you compare the improvement between last year and this year, we are doing tremendous. So last year at the same time in December, we were at 62%, and we've shot all the way up to 76%. And then we have 3 measures that are outperforming December of 2022's metrics. So kudos to everyone, and thank you so much. All right, next slide. Next slide, Sheila.
I heard you. Oh my gosh.
All righty. These are our pay for performance measures, and we have 6 measures that are meeting target, 1 measure within 5% of target, and 4 measures that are outperforming December 2022. So wherever you see the green arrows, we have improved tremendously. So BMI screening and follow-up, I know that is one of the ones that we shared in a provider meeting. Abina has also been walking around and talking to providers about how to follow up on our patients' BMIs, whether it's, underweight or overweight, and what to do to meet that metric. So we definitely have climbed up with that. Our depression screening, our cervical cancer screenings, we're doing great. And MET reconciliation post-discharge, we're doing great. So good work there. And next slide. And these are our MD-PCP performance measures. Again, we have 4 measures that are meeting the target, 2 measures that are performing in the 50 to 79th percentile, that's our yellow zone, and 5 measures that are outperforming November of 2023. So our depression screenings, our BMI screenings again, hospital follow-ups, which Fatima is the nurse that's primarily working on that. And she's doing a great job for the patients that we're able to reach and to get in for a follow-up visit. Next. And now diabetes care measures. I think a few months ago, we were like the top clinic in terms of performing and taking care of our patients with diabetes. So as you see, we have our kidney health evaluation, which was shared. Our numbers have improved for that. That's that microalbumin screening that we're checking our patients' kidney functions. Our diabetes blood pressure control, we're doing well. Diabetes eye exam, the numbers have improved. There's still room for improvement, so we're going to be working on a same-day workflow for that this year. More to come. And then managing statin therapy in our patients with diabetes who do not have cardiovascular disease. We've had an improvement there as well. So great work. All of our measures are outperforming last year. And this is just a visual. And Abina's not here. For those who don't know, she's out until I think the end of March. I want to give her some kudos, even though she's not here. If you look at our trend for our annual wellness visits from March to December, amazing work. And I put the stars here because she started in her role in September. And in September, we've seen a climb from 63% to 76%. And we're just almost at target, which is 80%. So I want to thank her, and I want to thank you guys for working with her on getting the annual wellness visits done.
Amazing.
And this is just another 6-year trend of all of our core metrics. As you can see, nothing is gone down besides the A1C, which is supposed to go down because this is a metric that's lower. The lower is better. But from 2017 to now, we have gone up. So let's just keep going.
Trending in the right direction. Why did it stop? I was trending in the right direction too. Well, okay, next.
All right, so I just want to talk about our continued quality improvement workflows. Just to reiterate, for our mammograms, if you have patients present in the clinic and they're due for their mammograms, particularly our patients who you've ordered it for many, many times, including the Priority Partners patients, they can go over to JHOC for a same-day mammogram. And the way that works is they have to be present. You'll just let the CMA know, like, hey, this patient has agreed to go over for the same day mammogram. Each zone, they have these little pink routing sheets that they would give to the patient to go to checkout. So checkout is aware, and they will call over to JHOC and order the patient to schedule the patient to go for a mammogram. Now, it has to be a screening mammogram. It cannot be a diagnostic mammogram. And I attached a workflow here. If you guys can't access it, we can always share it. It's a full workflow. So try to target your patients during the visits. If, like I said, if they're interested, let the CMA know. You can secure chat me and let me know if you have any questions. When Abina returned, she was working really hard on this and trying to look ahead of time and see if there were patients who would be willing and able to go over. So that little, our numbers have increased in the last few months in mammograms, and I really believe it was Abina's help with, reaching out to patients during the clinic visit. So she's not here, but if we can try to keep that going, we have plenty of support here that can help you guys with that. And then just to discuss our wellness visits that we're doing so well, and I want to continue. This year, in January, we started with the new annual checkup. So you may have seen some of your patients scheduled for an annual visit that indicates that they needed a wellness visit to be done. So just be looking out for that and trying to get them done if possible. And if it's not possible, which I understand, sometimes our patients are complex and they, need more time, or you just can't address it in the moment, that is fine. It's understandable. Just make sure that you send them to check out with a note in the wrap up that says, please schedule for annual checkup. And you can indicate if you need a 60-minute visit with this patient, but it has to be specified to the PSC staff so that they know. If you have patients that no-show or cancel and they were scheduled for their annual checkup, if you could just send a message to the PSC that's assigned to you and your RN and just notify that they need to be rescheduled. And if you have a follow-up patient that's scheduled and they were not due for annual exam, or they were not changed to the annual exam, and the reason why that may happen is because this visit type change is happening internally. So, when we've had the visits changed over, if there's a patient added on within the week or 2 weeks and we didn't get to have the visit change, you may see that they're only in for a follow-up. And if you have time to flip the visit, please do so. And you just let the CMA know, like, this patient is here for follow-up, but I'm going to go ahead and do their annual wellness visit today. Can you do the HRA questions with them? And after completion of the wellness visits, to keep this going, it will be helpful if you put in your note to have the patients scheduled for the next year if your templates are open. So if you're doing it in March and that they're going to be due for another one in March, if they have Medicare, you can ask the PSCs to schedule it. And any follow-up in the interim can be scheduled as well. And then for those who don't know, we have a yellow brick road to wellness. I wanted to take a picture and put it in the slide, but I didn't get a chance to do so. It's over there. Sheila, what zone is it next to? You're on mute. You're on mute, Sheila.
I know. I've got to get to the button. But it is, as you're walking people to check up out, it's in that hallway.
Okay, so yeah, so it's whenever you complete a wellness visit, this is just a visual aid, something to kind of, have some boost of camaraderie around it. You get a yellow brick from the CMA. They all have them in the zones, and you put your name and the date that you did it. And we're hoping by the end of February to have a whole yellow brick road to wellness. So just be on the lookout for that.
We're going to keep it going. So follow the yellow brick road.
Next slide. All right, metric of the month. If you may have noticed that it's on the eHuddle, every month we're going to try to have a metric of the month and have information, best practices there to help support you guys. So this month is controlling high blood pressure. That is a measure that we're always almost at target. I think last time we checked, it was about 3 or 4%. And the way that we can meet this metric is, number one, our patients' blood pressures have to be less than 140/90 in order to be compliant, numerator compliant. And it's always looking at the most recent blood pressure. Now is going to be as of 2024 for our primary care patients. And so whenever you have a patient who's in and their blood pressures are greater than 140/90, you always want to have them rechecked with the Omron after they've waited for about 15-20 minutes to get settled in. And if their blood pressure remains greater than 140/90, they have to be seen within 4 weeks. That is controlling our hypertension patients. We don't ever want to send them out of here and we don't see them again for 3 to 4 months. They can be seen within 4 weeks. You can have them come in and see their nurse for a nurse visit. Maybe you want to see if you change their medications, you may want to see them again, or if they're on several regimens and it's just not working, you can see Kristen PharmD. But you can utilize your nurse for follow-up. The nurses, so what we ask is that you do is notify your nurse that they need a visit within 4 weeks, and we can see them in person. Some patients we can do over the telephone. That's if they have a working blood pressure cuff, and this is a patient that, could be reliable enough to use the blood pressure cuff at home independently. So please just let the nurse know what the goals are for the patient in terms of their blood pressure. Let them know if any medication changes were made. And that can be done via staff messages or secure chat, and have them scheduled to see the nurse. Remote monitoring is an acceptable measure. So we have the MyChart blood pressure flow sheet that can be ordered for patients. If they're tech savvy, not all of our patients are going to be able to use that, but you know who your patients are who are pretty savvy, the ones who are on MyChart sending messages every day. They can put their blood pressures in a flow sheet, and it populates right into their medical record. And then for those patients who we would need to call and check in with and get their blood pressure readings at home, there's a flow sheet called patient reported vital signs that the nurses could enter the blood pressure readings in, and it's appropriate. If their blood pressures are consistently lower at home, lower than that 140/90, then we're meeting the metric, we're controlling their blood pressure. So that would take them out of the denominator. However, if they come back again in 3 months and their blood pressure is high again, they would go back in the denominator, and we would need to see them and keep tabs on their blood pressure. And so also, please, you can give your patients blood pressure monitors when it's appropriate to do so.
Hey, Steph, just real quick on the slides, 1, 2, 3, 4 bullets. It should say greater than 140/90.
Okay, I'll fix it. Thank you.
Yeah, thank you.
Excellent, thank you. And this is just a process map that Dr. Basef helped us with. She's always one of the providers that usually, if you look to the right, the dashboard will tell you what providers are, performing the best. As of December, it was Dr. Gilliams. Kudos to Dr. Gilliams. And then Dr. Basef was right under. So we worked with her last year sometime to do a process map. And so that's also attached on the eHuddle every day, just so that you can see the workflow. And that's pretty much what we just discussed.
And there is a question in the chat from Liz, which is about whether or not we have a supply of blood pressure cuffs to give out to patients in clinic. And
we do.
Yeah.
Yeah.
Mm-hmm.
And so what is the flow on that in terms of like, I was going to give one to a patient, and then because I had insurance, they said, we'll order it first and we'll coordinate it. And so I did that for that patient. Another patient actually gave it to him, and I do think it helps.
Yeah. So, I mean, providers.
I'm sorry, go ahead, Steph.
That's okay. Usually, when I'm covering providers, they come and ask me for a blood pressure cuff for the patients, and it's okay to give it to them. So the times when I have said, let's try to order it through insurance, is if we've given this patient like 3 blood pressure cuffs and they've lost them all. So just go to your nurse and obtain a cuff, and we have a way to document that we've given them one.
And also then your nurse can help the patient to understand how to use the cuff, send in their blood pressure readings, we'll follow up. So, it's just about, saying to your nurse, look, this person's blood pressure is greater than 140/90. We need to coordinate so we can get this blood pressure under control. I want to give them a cuff. Can you teach them how to use it? Can you start, maybe weekly getting readings from them? The nurses will help with that. Next slide, Steph.
Yes, ma'am.
Next slide, Steph.
Mm-hmm. Yep.
Am I frozen?
I can hear you.
Yes, next slide, Sheila. Can you hear us?
Okay. Okay, yeah.
So that's the end. Keep up the great work. I just put a little quote here from Mark Twain: continuous improvement is better than delayed perfection. We are doing tremendous work. And so, I'll just keep you guys updated, keep it in the front of our minds. I know our patients need a lot of support, and we're going to do the best that we can. So far, we're doing very well. So thank you so much.
So I added a couple slides, Eileen, just on the end. First of all, thank you, Stephanie, so much. Great work with you and Abina, and just great work, everybody. I mean, as you see from the beginning of Stephanie's presentation, we're trending up and continue to trend up. So I just appreciate everybody's hard work in helping our patients to be healthier. So I know I've sent this out a couple times, but this is from Lisa Maragakis. This is the measles guidance as of now. Hopkins HEIC has not implemented active screening procedures for measles and will not likely do so unless there is a local case. If a patient shows up to clinic with symptoms of fever, rash, upper respiratory infection symptoms, it's best to have the patient, like we just do with COVID, put them on a mask, put them in a private room with the door closed. You could put them in the negative pressure room if no one is scheduled to be in there. So you always have to check that. And then wear respiratory protection to assess them for any known exposures or links to measles. If there are none present, they can be evaluated if usual. If the links or other signs and symptoms raise the likelihood of measles and airborne isolation is not available, then they need to go to the ED for further evaluation and have them leave the clinic as soon as possible. We should be calling ahead to the ER and letting them know that a patient is coming with measles. We should do it in full PPE. If the patient calls the clinic and they have concerns about measles, it's best to refer that person again to the ED or someplace not here for evaluation, because that, negative pressure room is just not a really good place to evaluate people. It's small. And again, let the ED know that you're sending somebody to them with potential measles. And then there's just some helpful links here for screening. And yeah, that's it about measles. So I just wanted to let everybody know about that. And then this is just I keep getting these emails from people saying, well, we used to do it the other way. This is from Heba in microbiology. She's in charge. She said, this is how we collect for STIs. The vaginal, rectal, throat collections are with I want to get it right, the woven swab.
The giant Q-tip.
That's right, the Q-tip. That's what it is. It's a Q-tip. The endocervical collections only are with the flock swab. So I just made that picture and I just wanted to show it again. I know it's been happening the opposite way. So we just have to all get in the practice of doing it this way. And that was all I had today.
Well, no, you can just leave this picture up because I had asked that Matthew Hamill give us a special pop into this discussion of which swab to use. So now that I have a picture too, but your picture is beautiful. So Matthew, and I cannot remember, but I did think the Q-tip was basically just a Q-tip and we just use it for cleaning in the flock swab because it has all
what
these
everybody
tendrils and it's supposed to collect all the cells. It sounded so much superior, but Matthew, tell us.
I've nothing really to add to his great picture, which is certainly better than the one that I'd also prepared. Yeah, it seems counterintuitive, but that's the rule. And I think
and Matthew, it's for all labs, because I had somebody come back and say LabCorp Quest, and I wanted to confirm it's for all labs like this.
It's a different kit for LabCorp Quest. This particular kit is for Hopkins.
Okay,
There's a different kit for LabCorp.
Okay. But is it the same cotton swab versus flock swab? I'll look at the kit for LabCorp and Quest.
LabCorp is the orange one for vaginal and
I will send out for LabCorp and Quest.
yeah, I think that it's hard to get that one wrong. This one I can understand why people get them mixed up. And I used to put them both in if I wasn't sure, but that's also
And not supposed to do that either. Yeah, Heba said that. If they're gonna start rejecting these, yeah. One swab.
I will say that the flocked one, like it's not that strong. So I think I tried it once in a rectal and then stopped because it like just doesn't, it like bends a lot. So that's a good redirect to the Q-tip. Also.
Yes, the Q-tip.
And
Really, the only people that are doing this are GYN.
And I just wanted to mention, we do have now this Bartlett SharePoint, and if there's a little bit of time, I'm going to share my screen. And I asked Abby to bookmark it on all of the workstations in the clinic. So
That's a good idea,
they
Joyce.
wouldn't allow.
Actually, why don't Joyce, you just share it while you're talking now? So, because we do have a little bit of discussion, so we don't
And
have
just real quickly, can I have one more minute before you go do that, Joyce? I didn't make a slide for this because I wanted to get some confirmation on the CUS meeting that we just had at 11 o'clock. You know, chaperoning is coming down the pike and is going live on April the 15th. And that is that patients will be asked on rooming, if there is going to be a sensitive exam today, would you like a chaperone? And if patients say yes, then you will have to have an MA in the room. It can't be your resident. It can't be a medical student. It's gonna have to be a CMA or a nurse. So that could really change practice. Sensitive exams include basically anything that you wear underwear on. So that will be buttocks, genitalia, breast. So just letting you know, that's coming down the road, April the 15th. You will be
And Sheila-
required to take, you will be required to take some trainings, and I will be setting up those trainings. Eileen, I think we need to do that in March on one of these Fridays.
And Sheila, can I just ask, will that be documented by the MA like in
Yes.
vitals? Because,
Yes.
you know, I routinely ask patients, and then may write it in my note or not. Like that's just always been my practice about those things until I know somebody. And if, you know, but it will be a checkbox and that will come up and the MA will, okay.
They will be asking, my understanding of it, and remember, I'm learning too, but they will be asking if you're going to have a sensitive exam. And again, the easiest way to say that is something covering your underwear or your bra, okay? Would you like to have a chaperone? The patient can opt out and there will be a button to opt out, right? If not, then an MA, someone else will have to come in with you during this exam, and then their name will go in. The MA will put their name that they chaperone during these exams. So, more to come on that, but I just wanted to get you guys ready because believe April 15th will be right around the corner. So we're gonna have some trainings. And Eileen, should I reach out to Laura about setting up a Friday?
Yeah, sure. That's great.
Okay, cool. Thank you. That's all I have today.
Great. So Joyce, do you want to share your screen to show us the
Yeah,
SharePoint?
I'll just share real quick, and I put links. It's
In
not
the
allowing
chat.
me. It's not allowing me to. Well, someone else.
Sheila, can you stop? Thanks.
Okay. So I'm just gonna share my screen here. So this is am I sharing it? Okay, so this is the ID intranet, and I put the link to that. And then there's an ID clinical space, and then we have our Bartlett specialty practice. And I've started populating. I send items to Key Holloman. She's one of our admin people, to start populating things in here. It's fairly sparse right now, but you know, I sent the swab thing that Sheila just showed, and it's going to go under clinical resources and guidance. I'll put in, I think I might just do like a measles one here while it's like a thing, you know, to be on the lookout for, and then maybe move it into clinical resources and guidance. I'm updating our anal cancer screening guidance and like referral instructions. That'll go into clinical resources and guidance. So I put the links in there. All of the ID folks are automatically have access. For people who are not in ID, you need to request. And I'm sorry that I can't just give a list. I was told I cannot give a list, but apparently there's a way to request access. I can find out more details if that's not straightforward. But I asked.
So I can just say I clicked the links, and the Bartlett one I got to no problem. The ID intranet one, I actually got to a thing that says I don't have access, and you just click I would like access, and then it sends a request. So
yeah, okay, perfect, good. So so take a look, give me suggestions. That way, whenever there's any of these new emails coming out, we're gonna populate this. And then Abby has bookmarked it on all the workstations. So some have Chrome, some have Edge, but she has bookmarked them. If you see a station that it's not where it's not bookmarked, you can let Abby and me know.
And Joyce, I just sent you the PowerPoint that Stephanie did. And it also has the measles guidance with all the links.
Okay, perfect.
That was the slide before my testing specimen collection was and that was the stuff that Lisa Maragakis sent to us yesterday.
Great, thank you so much.
So I just sent you those slides.
Thank you.
all right, well, awesome. Thank you so much for all this update. Thank you, Stephanie and Sheila, and for all you do for our patients and for keeping us on track. So we have a little bit of time left to talk about some cases, so we'll get started with